because clip is more.
Okay, we can do the same talk that you just had. So this is now after the tricuspid. So by the way, we did the first tricuspid valve replacement also, first in man, recently. So there is a tricuspid valve replacement in a native valve that has been done with a navigate valve. So now this is the mitral valve therapies. We wrote this editorial to say that how do we select mitral valve therapies? And there is a lot of different ways, but this is actually the figure that was in New England Journal to say that how the tethering happens and how the annular size increases. And in some, the repair may be better, some the replacement may be better, annuloplasty, leaflet combined, or valve replacement. So this is the key, that there are three different ways, and you will learn about the MitraClip, so I'm not going to talk about the MitraClip, but direct and indirect annuloplasty, and there are 4 of them. So there is Carillon, Mitraline, Cardioband, and Millipede. Millipede has still not that much of percutaneous data. So they have implanted Millipede in surgical patients, but not in percutaneous therapy. Carillon, Mitraline, and Cardioband are all progressing. Mitraline, as I said, not so much for the mitral. So currently, Carillon and Cardioband are going to be available in the United States. What is Carillon? So Carillon, I'm sorry, if you go back and maybe click on it if it plays, please. If it doesn't, it's okay. Okay, that's fine. So the Carillon is a device that goes into the coronary sinus. This goes distal part of the coronary sinus, and this comes in the very more proximal side of the coronary sinus. This device is placed from the IJ. It is 10 minutes procedure, and it does not cause any, you can have anything else you want to do without a problem, meaning that you can still do MitraClip, you can still put a valve, you can still do bi-V pacing, and the coronary arteries can be managed in 90+% of patients. So this is a unique device in that sense that it is extremely easy to do compared to anything else we do in the mitral space. So this is the device. So it goes through the IJ into the coronary sinus. As you can see, it is in the coronary sinus. You measure first. You measure the coronary sinus with a pigtail catheter, and then you deploy the device, and then you pull it as much as you can. There is nothing to check in the sense that the valve, whether the MR acutely gets better or not, or anything like that, nothing, because acutely the MR gets better in some patients, but not in all patients. Eventually the MR gets better as time goes, and I'm going to tell you why. But this is a very different strategy. What is the advantage of this device? So initially, in 2005, we wrote a paper saying that, hey, listen, coronary sinus and mitral annulus are not in the same spot, and it's a bad idea to put something in the coronary sinus. This is exactly now coming 360 degrees backwards to say that what we said was not accurate. Because if you look at the MR, unfortunately the movie didn't play, sorry about that, but the MR gets better over time. I want to tell you something. So this particular protocol is now approved in the United States. We are going to start a randomized trial in 40 centers. This is the first time that we are going to include patients with so-called active control. What is an active control? Is a sham operation in the sense that people are not intubated. This is conscious sedation. You put a catheter in their IJ, do a coronary sinus angiogram, and if they're candidate, you randomize them. So they need to have a certain size of the coronary sinus. You randomize them. They don't know which way they're randomized, and within 5 minutes after you do the coronary sinus angiogram, you can put the device. So FDA allowed to do this trial in patients who are not really surgical high-risk patients. So this is going to be available for anybody with 2+ mitral regurgitation, not 4+ mitral regurgitation, 2+ mitral regurgitation, who are symptomatic, and ejection fraction up to 50%. It is not for the patients who are now going to be surgical rejects. So because there is no indication for surgery in 2+ mitral regurgitation with 50% ejection fraction. And what is the indication is that if patients are symptomatic, then they should be on optimal medical therapy. And optimal medical therapy is diuretic, ACE inhibitor, and beta blockers. And if they are just taking these medications and stable diuretic dose, then they can be randomized. So not like COAPT, much simpler criteria to enroll them in the trial. This particular trial is going to have a 6-minute walk as the endpoint because it's sham control trial. And we are going to start selecting the sites as early as during the ACC. So stay tuned for this particular trial because it's a very exciting trial. The main reason is that this particular device takes away the atrial pull on the annulus because it is on the atrial side of the annulus. So if you put the device in the atrial side of the annulus, the atrium can no longer stretch the annulus. So the atrial mitral regurgitation, people with functional mitral regurgitation who have more atrial problems are better treated with this device. That's the theory. And that's how we are going to design the trial. I'll just skip the mitral line. The Cardioband device, as Bridge mentioned, is a device which is a very, very nice device, but again, is a complicated device in the sense that you have to put all these different screws in the annulus. So you have to put all these different screws in the annulus and then pull the band. And I wrote an editorial for this particular one also when they had their initial feasibility data, again, showing that they had outstanding data, but how easy or difficult it is going to be is a question. This is not as easy as doing a carry-on device, obviously, because this requires quite a bit of skills. This is another amazing fact that transcatheter mitral valves in 2015 had more than $2 billion invested. And so this is from Valtech, from Tendyne, from Cephea, from CardiaQ, M-Valve, and 12. So these are all major companies invested tremendous amount of money on the mitral valve. So it is impossible that it can fail. You know, if you put so much effort and so many good people and so much money, it got to succeed. So this is likely to succeed over time. We have experience with at least 3 of them. Difficult. Okay, this putting a new mitral valve in a mitral position is not at all in any way or form similar to the aortic valve replacement because it's a very difficult endeavor. Tendyne has the best data. So CardiaQ, now Edwards, is a valve. As you can see, this is the part that stays in the ventricle. This is the part that stays in the atrium. You know, it's a very bulky device in the atrium. It has these little screws by which you anchor, the ventricular anchors, as it says. And all of these devices are big, as you can see how big it is. So the anterior mitral leaflet and LVOT obstruction is not a trivial thing for these devices. So you have to select the patient who has a 25% EF, the ventricle is large enough, EF is not bad enough, and LVOT is large enough. So out of 40 patients you screen, you get 1 patient in this trial. So this also tells you that currently it's going to be very, very difficult to generalize this therapy in a large number of patients. Neovasc Tierra, I don't have much experience, but it is, Webb had done some studies. Transapical valve, it is not a transfemoral valve, and it's a D-shaped valve, and it has a mechanism to catch the anterior leaflet, so it does not cause any SAM. Tendyne sounds a little bit scary, but turns out to be the most simple device. So it is a very, very simple device. So it's a valve. You collapse the valve, and there's a thread, and there is a little paddle. So you go in from the apex. There is a transeptal version of this too. But you go through the apex, put the valve in, open up the valve, and then pull it, and bring it to the apex, and then put this pad on the apex. Sounds, and doing it. It is one of the most reproducible valve, at least in the mitral position, than anything else. When initially we said that, my God, we are going to put a pad and all these things, Very simple. It's very simple. And if it doesn't work, you take it out. You can retrieve it. This is a patient, for example, one patient, this 69-year-old lady, but this will highlight what it takes. So this is a 69-year-old lady, bypass surgery, all these different kinds of coronary problems, TR, MR, CVA. How do you know that she's short of breath from what? She's short of breath from mitral regurgitation, coronary disease. I'm sorry, it doesn't play. But the right coronary artery was totally occluded. There was a severe in-stent restenosis of the circumflex. My fault. And the lima was patent. So the question was that this particular patient, what do we do? So we have to open the right coronary artery. So we stent the right coronary artery. We open up the in-stent restenosis circumflex. Then we do an echocardiogram, and we find severe mitral regurgitation. Then we bring the patient back, put them on the treadmill, and then do the tendyne valve. So, it is, see here, so we recanalize the circumflex, we recanalize the right coronary artery. 2 months later, we bring back the patient, metabolic stress test, MVO2 is still low. We think that now this is the cause of shortness of breath. But, you see that how long it takes to enroll one patient in this trial. Severe MR in this particular patient. And so here you go from the apex and with a finger. So there is a little finger here by which, because where you puncture is very critical, because that's where you're going to anchor. So you have to puncture in line with the mitral valve. So you decide exactly where you're going to puncture. This is open. So this is open surgery, but you have to identify exactly where you're going to go in by the finger. There are a lot of different ways. And then you put a little balloon, cross the valve, make sure that you're not through the cords, and then you put this big sheath. It is 36 French going into the heart, but again, it's apical. And then you put a valve. You open up the valve and slowly expand the valve. You see that you're expanding the valve slowly. And this is the valve expanded with the proud cuff. They call it a proud cuff. This is the part that is longer. And you adjust it, you pull it to the apex, and it no longer leaks. So if you pull it hard enough, it doesn't leak. So then there is a barometer to it. So you make the pressure in that line 250, 260 millimeters of mercury. So it is about 130 millimeters more than the LV pressure. So it creates a little dimple on the apex, and it measured, it's scientific. So you put the pressure, you measure the LVDP, you measure everything to make sure that it's not causing diastolic dysfunction, and then you let go the device. And it looks like that. So they come in two different sizes. This is a larger plug, there is a little smaller plug, but we put a larger plug in all the patients that we have done because, again, it prevents the bleeding. This is the plug. If it bleeds underneath the plug, that's a problem. But so far, for us, it has not done that. And finally, the patient did not have MR. This patient did very well. So now the tendyne is the only valve that has large data. Now there are 100 patients. First 30 patients we reported in this particular paper. Old patients, again, as I said, it's very, very hard to figure out. There are a million reasons for them to be short of breath. All of them are in atrial fibrillation, all of them bad EF. So how do you know that the MR is causing the shortness of breath? But this is the tough part. But no death. 0 out of 30. This is most amazing, because to have a valve this kind and no death is just unbelievable. And hemodynamics, very good. The thrombosis risk of this particular valve is not 0. So there were 5 or 6 patients that have been now reported to have a thrombus on the leaflet, very similar to the aortic valve. But again, the INR has to be 2.5 to 3.5. I keep the INR closer to 3.5. So remember, these are biological valves, but they require Coumadin at that level, at 3.5 INR. Which device will work? So I put this graph to say that if you have efficacy, safety, and applicability, they are all interrelated. Of course, the best device would be very effective, very safe, and very applicable. It doesn't exist. So I think, personally, a device that is very safe and you have more options to go further in the mitral technology is a winner, because it will be easy to put, and it is not particularly difficult. If it works or not is not so critical. If it works in X number of people, it's still okay, and that would be the strategy. So it's a complex disease. It's very, very hard to figure out what is the contribution of the MR to the symptoms. There is unmet need. The COAPT, Carillon, and Cardioband, and TMVR are the three main areas where you're going to see activities in next year or so. And safety and efficacy, both are important. I think safety will be more important than efficacy because people are not dying from this disease, and we are trying to just make them feel better. Thank you.
So I think we have just the mitral clip talk before you guys